Thank you. I appreciate it. Wonderful introduction into why we're all here. Welcome to Atlanta, everyone. I feel like it's Old Home Week because I get to see a lot of old friends that I haven't seen since this time last year when we had the symposium. So it's nice to see everybody again, and it's nice to see new faces who are a part of PCNA now and are here to learn. I'm going to talk more about the Chorus CAD test. We're going to go over case studies at the end so you can see how to clinically utilize it in your practice. So some of this will touch on some of the slides that you've already seen before, and then some of these are going to be new slides and hopefully clinically relevant to what you do in your practices. So one question people already ask me is, well, what kind of test is it and what makes it different than some of the other lab tests that we do? Right now, if you go to the ACC conference, if you go to the NLA conference, if you go to any of the big conferences, one of the big discussions people are having is DNA testing. There are several companies out now that are all talking about DNA, doing DNA testing. This is very different from all of those companies doing DNA chromosomal testing. If you actually take a look at the difference, this tells you what the genetic testing is, and then this tells you how the gene expression testing is different. So if you take a look, the gene testing is actually telling you what genetic traits an individual has. And that is a DNA chromosomal trait, and that's not really going to change. But if you look at gene expression testing, it's looking at what effect does your genes have on your messenger RNA. It's very dynamic. It's going to change according to what's going on at that period of time, as opposed to just setting you up for what may or may not be in your future based on your DNA. There's a lot of genetic tests out now that are talking about, do you respond to this drug? Do you respond to that drug? Which one is better to use after CAD? This is very different than that. Now, we've all seen this structure before. This is the progression of plaque in the arteries. I'm sure some of us still have the little plastic models that we've been given through years past, and we use it for patient education. So we all know what happens with the monocytes to macrophages to foam cells, and it all creates plaque in the system. But we know a lot of what spurns this process is inflammation. So what do we all have to do now in clinical practice? Evidence-based medicine. If it's not proven, then why are we doing it? What supports it? So this is information just to let you know that the Chorus CAD test is well supported. Multi-center prospective analysis, peer-reviewed information to show the validity of the test and the clinical utility of the test in practice. So if you actually look at the test, you want to make sure that it's highly sensitive, which Chorus has proven to be very sensitive and a high negative predictive value, which was discussed previously. And in looking at this information, going back and reviewing those research studies, Chorus CAD test has been proven to be highly sensitive, up to 89% sensitivity. Negative predictive value is 96%. So what this means is that if you get a low score, the odds at this being obstructive disease is not that high, okay? So that's the negative predictive value. You do this test and you hope you get a low score, so it's reassurance it's not obstructive disease. And as discussed before, in the COMPASS study, which was a low to intermediate risk population group, by far the Chorus CAD test outperformed MPI as far as negative predictive value and sensitivity. So when evaluating patients, like as discussed before, your risk-benefit ratio, what are you going to get out of doing these tests on an individual versus what are you going to put them through? Sometimes it's great to have a reassuring number to be able to reassure a patient that the likelihood that it's obstructive disease is much better through a blood test than through putting them through more radiation. Once again, going back to your validity of the study, this is looking at the previous studies which have shown us all of these individuals in the study received both the Chorus CAD and either CTA or coronary arteriograms. And what it found was that the number score you received on the Chorus CAD test directly correlated with the extent of obstructive disease. So the higher the score, the more likelihood, the higher the extent of the obstructive disease. Insurance companies do not want to pay for something unless they have to, unless there is documented clinical reason. So out-of-pocket costs are huge. And evaluating the cost to your patient is something that I think is going to become more and more prominent. So I think that's one way this test really holds a place in your clinical cascade when treating patients. If you have two patients, both of them walk into their PCP office, okay? They're having chest pain. All right, so one PCP refers to a cardiologist. You have your little cha-ching right here. Cardiologist then recommends an MPI, which gives you a cha-ching plus radiation. So you see that right there. And then sent to the cath lab for a nice chunk of change right there, only to find out the patient didn't have obstructive disease. Do insurance companies like this? No. Happens all the time. So what can we do to cut down on the healthcare costs? Patient goes see the PCP. PCP gets a Chorus CAD test. The score is 10. So when you perform the test, a low score is 15 or below. So the likelihood of obstructive disease, if their score is 15 or below, is pretty low. So 16 to about 28, 27, somewhere around there, is your intermediate risk. That to 40 is your high risk and pretty likely to have obstructive disease. Needs to go further through the cascade. So this individual ended up having a Chorus CAD test. The score is 10. So the patient, because we're all patient-centered, gets appropriate care, gets effective care, and they get to feel like they're important. And our insurance companies are happy because they don't have to pay for a CAD. So this is what it looks like. The great thing is it's so easy to do. It's a blood test. Okay, so either your lab can do it if you have a lab in your office, the hospital lab can do it. It's simple, it's safe, it's convenient, it's one tube of blood. Doesn't matter if your patient is fasting or not, they can have it done anytime. Blood does not need to be spun down, so you don't have to have a centrifuge. Okay, turnaround time is 72 hours. Patients do not have to take more time off of work to come back for more testing. They don't get the radiation. So it's a win-win situation for all involved. This is what the sheet looks like for the patient results when they come back. That's your score right there in the big red box. And then it gives you the percentile for likelihood of obstructive disease. How simple is that? So once again, we talked about women. I think there's been more and more of a push with the American Heart Association on treatment of women. And as we discussed earlier, women can be challenging. They don't present the same, different symptoms. So what can we do to better treat our female population? There's no easier way than instituting this blood test into your clinical cascade of treating your patients. You saw this slide a little bit earlier. This is looking at the PREDICT data. Okay, once again, all of these individuals receive catheterization. The overall diagnostic yield for the PREDICT study for catheterization in all individuals, men and women, was only 37%. So in the whole study, there was not a whole lot of obstructive disease. Then we come to find out only 22% of the women had obstructive disease. So that's a big test for a small percentage of women to find out they have obstructive disease. It's a highly sensitive test. The negative predictive value is 96%. The great thing is, when looking at the patients that have been tested through Chorus CAD, 46% had a score less than 15. All of those people we save from further cardiac workup. All right, so let's go through some of the patients that I've seen in clinical practice. This is a 65-year-old Caucasian female. She came in complaining of shortness of breath and a very vague, unspecified chest pain. Pretty typical sometimes for a lot of my female patients who are postmenopausal. She has hyperlipidemia, high blood pressure. She has a genetic marker, the Lp(a), which we had gotten down from 407 to 195. She's only taken lisinopril, and we had started her on a cholesterol medicine. So she had been in, she's a long-running patient, had coronary artery calcium score in 2009. Her score was 59, predominantly in the LAD. This transpired into the next step of having an MPI in 2009 and 2010. Guess what? They were negative. Okay? But the patient's still having symptoms. All right? That's what we can't forget. So on this follow-up visit with me, I introduced the Chorus CAD test to her. And I said, well, why don't we do this and let's evaluate. Is this something we really need to worry about, being obstructive disease and just they need a cath, or can I be assured that we're dealing with something else? So we did the Chorus CAD test on her. Her score was 6. So the likelihood of obstructive CAD on her was only 3%. That reassured me, it reassured her that she wasn't going to drop dead in the middle of the night and leave her family without a mom. So this is what her patient report looked like. As you see, it's very bold to tell you what the patient's score is. And she was only 3% in the likelihood of having obstructive disease. So what happened? I saved her from having another MPI, which is more radiation, more money. At our institute, we send a bill for $9,000 to their insurance company for an MPI. That's a lot of money. So now we were able to just really work on her risk factors. She's one of those statin intolerant people, so she doesn't want to take her statin if she doesn't have to. But we're able to work on her high blood pressure, work on her cholesterol, and continue working on her Lp(a). This young girl is a 42-year-old premenopausal Hispanic female. Came in complaining of shortness of breath on exertion. Anytime she walked, she would double over. She was so short of breath. She had a heart murmur. We had done an echo on her, and her heart murmur was benign, so that was not causing her shortness of breath. But she did have family history of coronary disease. She was obese. High-stress job, working in a lawyer's office, so we all know that that could be stressful. She was on no medications. So we did a calcium score on her. Her score was 0. Her echo was normal. And she kept complaining of this shortness of breath. So I said, okay, let's just do a Chorus CAD test on you. Let's make sure that there's not obstructive CAD in there that's just not presenting itself typically. So we did the Chorus CAD test. Her score was 5. The likelihood of obstructive disease was 2%. So that was able to save me from this huge workup of trying to find a needle in the haystack. Now I see her shortness of breath is resolved because she's changed jobs. But of course, you never want to make any assumptions. You need a valid test to give you some reassurance as to you're treating a patient appropriately.